everyone. Can you all hear and see me okay? Great. My name is Khyati Somyaji. I am a fourth-year medical student at Temple University, and today I'll be sharing an interesting case that I came across with a very young patient who presented with a unclear and unidentifiable etiology for acute necrotizing pancreatitis. And the unique aspect of this case was sort of figuring out the differential diagnosis that wasn't as clear to us for a typical case of pancreatitis. So I'm going to just kind of walk through the case presentation. So this is a 21-year-old female who had a past medical history of similar episodes of idiopathic pancreatitis and also had presented with your typical, presentation of a pancreatitis with the abdominal pain, fevers and chills, nausea, vomiting. Her lipase was elevated to 14,000 with pretty significant leukocytosis and a lactate of 6.4. You can see some of the CT scans on the images A through C, and I'll walk through those a little bit later. But on her initial presentation, she had a decreased attenuation of her pancreatic neck, body, and tail with some pancreatic fat stranding and fluid concerning for necrotizing pancreatitis. She, as her hospital day course went on, she was started on a 5-day course of meropenem for severe sepsis and developed hypoxic respiratory failure and was actually admitted to the ICU for a night. So really severe presentation. In terms of the imaging, we can kind of go through that since it goes through as part of her hospital course. So in A here, this was her presentation on 9/18 of 2022. Her initial CT, you can see near the pancreas, right in the middle of that scan there. At that point, there really was no walled off fluid collection or anything like that. But if you look at B, which was her presentation a few weeks later, you could see a development of very severe, very large, complex fluid collection measuring about 18 by 20 by 27 centimeters. And then you can see a couple of weeks later, you can see a little bit of the narrowing of the splenic, superior mesenteric and portal veins. So she developed these thromboses and the inflammatory changes that came with that. So a little bit more about her hospital course. She was being worked up for all the different kinds of etiologies for pancreatitis. She didn't have a big alcohol consumption history, had only had a few drinks socially. There was some, concern for gallstones, but on further examination, she had no signs of that. Pancreatic divisum and biliary sludge were also ruled out with MRI and MRCP. In terms of some of her genetic testing, though, and her IgG markers, so her IgG 1, 2, and 3 were low, and IgG 4 was normal. She was positive for ANA. So those are, again, some interesting exam finding or lab findings that came through for her case. She then later, so 7 days later, she was readmitted to the hospital. This was in the October admission. And as I mentioned in the CT scan B, she was found to have this multiloculated fluid collection for which a stent was placed. She had a necrosectomy due to a persistent fluid collection, and eventually the stent was removed. At this point, her endoscopic ultrasound was normal. She was discharged, and she still continues to have close outpatient follow-up. So I'd like to draw your attention to the discussion here, mostly kind of, figuring out what was the etiology of this. You can have a lot of complications for acute pancreatitis, especially with her thrombosis and walled-off necrosis. But in such a young patient, the two most common things we think of are gallstones and alcohol use, although both were ruled out. So, at this point, the differential diagnosis, we had idiopathic, autoimmune, and microlithiasis-induced pancreatitis. So even, a gallstone smaller than what we could have seen on typical ultrasound imaging. Of these, it was interesting that type 2 autoimmune pancreatitis kind of fit the constellation of her clinical and immunological markers that came about in her lab findings. So this was an interesting discussion that we had, considering, her IgG4 level was normal, and you would expect this to be typically elevated or altered in some way, but in young patients, this can actually present to be at a normal level. And so that being normal, type 2 is more likely than type 1. We would need to have done, further histological studies to confirm the diagnosis. However, like the benign findings on the endoscopic biopsy don't necessarily rule out type 2 autoimmune pancreatitis. It's considered when corticosteroid treatments improve or resolve the symptoms, but the patient that in question here did not receive any corticosteroids due to her positive bacterial culture, so we were unable to assess in that sense as well. So as I mentioned, she continues to be followed outpatient GI. She is undergoing some genetic studies to see that there was any alterations here. She was found to be heterozygous for the CFTR mutation, which is more consistent with chronic rather than acute pancreatitis. And most recently, ultrasound had indicated gallbladder sludge. But at this point, type 2 autoimmune pancreatitis still can't be excluded. So it still remains in the differential, and the definitive test would be histological studies, which would be the next step that we would take. Otherwise, very interesting case that came about with a very young female patient. And I'm open for any questions.
Alrighty, thank you very much. Are there any questions? All right, thank you so much for your presentation. We can go ahead and move on to the next presentation.